1 in 5 Ontarians visit the emergency department at least once a year. This is a relatively high number and leads to overflowing patients in hospitals. Many governments, especially ours, are invested in this problem. Ontario's government contributed $90 million this year towards creating more hospital beds to reduce hallway medicine. Overcrowding is an ongoing issue in many hospitals worldwide. It leads to serious risks to both the patients and the staff, including increased risk of disease transmission and more negative outcomes caused by increased waiting times. A solution needs to be implemented to reduce the effects of overcrowded hospitals. Many studies have shown that point-of-care testing can potentially alleviate overcrowding in emergency departments. Point-of-care testing is beneficial as it increases efficiency in the workflow process as testing is performed in a clinical setting. It increases the speed of test results, which also increases the speed of decision-making. It also involves portable devices and allows for testing in a variety of locations. A study performed in the UK demonstrated that point-of-care testing reduces a patient's length of stay. It was a quantitative study conducted in 2 phases. The first phase involved the hospital's centralized analyzer, and the second phase involved point-of-care testing. In both phases, the renal function of 10,868 patients was being analyzed, and none of the subjects had a minor injury. The time between arrival at the hospital and being ready to be seen by a physician was evaluated, and the 2 phases were compared. A key finding from this paper was that point-of-care testing reduced the time between arrival and consulting with the physician by 20 minutes. Many other studies have also been studied on point-of-care testing. The main reason as to why these studies took place was to analyze whether point-of-care testing can reduce the time patients spend in the emergency department. Increased waiting times and presence of patients lead to a situation where there are more patients than resources, which compromises the patient's quality of care. A similarity between these studies is that the dependent variable is very similar across studies. They are all measuring time, whether it is the total length of stay, turnaround time for results, waiting time to consult a physician, or disposition time. The methodology of these studies are also quite similar. All the studies are case studies performed with at least 2 groups, where one group receives standard care, which is the control group, and the second group receives point-of-care testing. These 2 groups are compared to visualize the difference and gain outcomes. The studies resulted in the same outcomes. Point-of-care testing reduced time. The differences between the studies are the measures of the independent variables. Some studies measure patients in the emergency department, some measure specific point-of-care testing devices and their impact. Other studies measure specific procedures and testing that patients are undergoing. These variances may be the cause as to why in some studies the reduced time is much greater than in other studies. Paul's study can also directly be compared to Goldstein's study, where both studies measure time spent and they compare the waiting time between access to results and the doctor's evaluation. In both cases, point-of-care testing reduced this time. The study between Singer and King-Campa are also very similar in methodology. They both measure patients' length of stay with or without point-of-care testing. The main difference is one analyzes patients in critical care and the other analyzes patients who enter the emergency department through ambulatory services. The differences in the type of patients analyzed leads to difference in time reduced, 33 minutes or 29 minutes. This may be because of the different processes that these patients go through. Likewise, the study between Badiola and Lin also measure patients' time consumed for an examination. The first one measures waiting times for a CT scan, and the second one measures total time spent in the hospital for an ultrasound. Since the first study measured specifically waiting time compared to the total time spent, this explains the differences in the results, a reduction of 50 minutes versus 73 minutes. But it needs to be remembered that waiting time is a component of the total time spent at the hospital. All the studies use a control group which increases the internal validity of the experiment. The studies also use random assignment where all the participants that fit the experiment's requirements are randomly assigned to a group, whether it is the control or the point-of-care testing group. Since the results also across the studies are similar, this area of research presents a high reliability. Most studies are not generalizable to all hospitals and settings due to the measures in each study. Additionally, many studies mention that point-of-care testing would be more effective as part of a workflow model compared to using it by itself. Furthermore, not all point-of-care devices may have similar outcomes, as different variables can impact the results. Lastly, due to the hospital setting, not all factors were controllable and many confound variables may have affected these results. Although a reduction of 20 minutes in length of stay seems insignificant, this number can make an extensive difference when you combine this reduction to the amount of people passing through the emergency department. The study estimated 7,032 hours of patient time saved per year. This can reduce the time patients spend at the hospital, thus reducing the amount of people at the hospital in a given time, and help alleviate overcrowding. In conclusion, point-of-care testing may change the experience of patients entering an overcrowded emergency department. It has the potential to reduce patients' length of stay and is as accurate as core laboratory testing. Since overcrowding emergency departments is a worldwide issue, point-of-care testing can have a global impact if it is implemented across hospitals worldwide, potentially eliminating overcrowding and allowing hospitals to be more resourceful. Further thought needs to be done to incorporate point-of-care testing as part of a redesigned workflow model for optimal results.